Has anybody really understood what an exchange properly done is? California choice is exactly right. What's an exchange properly done for a period of time called? California choice. Well, it's also called PAC Advantage. For a number of years, that was perfectly done. By the way, everybody says, well, a state-run exchange is going to be different. Where did PAC Advantage come from? A state-run exchange. And of course, why did it fail in the end? Because something went wrong. They weren't perfect. So exchanges in and of themselves are not a bad thing. A properly or improperly designed exchange may be a different case. So let's take a look right from the beginning. What happens? In PPACA, by 2014, January 2014, the exchanges must be operational. That's the federal law. If somebody says to me, Don, after you explain everything these exchanges have got to do, is there any chance that an exchange will actually be operational by that date? Probably only one state, probably California, because frankly, we've already got experience in it. Much of the implementation that we have to do is building on things that already existed. That's why our state exchange law was passed last October. Now, you read recently, probably within the last week, that the federal government gave us $38 million to develop an exchange. And somebody always says, well, what are we going to do with that money? We're going to pay ourselves back because we've already been developing the exchange. We've been working on it since October. We're light years ahead of the rest of the states in the country. So we will be up and operational January 1st, 2014. But if you think about it a second, that means there has to be somebody enrolled and insured 12/01, January 1st, 2014. If you were to start a brand new insurance company and you intended to have somebody enrolled, insured, getting medical care January 1st, 2014, when do you have to start, for example, selling? October. 3 to 6 months out. And in order to start selling, when do you have to start contracting for the rates with doctors and insurance companies and all that? You got it. So your customers, the public in general, will start hearing about the California exchange probably somewhere around the 1st of 2013. And that means you've got to be prepared by that date, because your customer who's coming up for renewal, he will literally be saying, if you don't understand exchanges, he'll be saying to you in June 2013 when he renews, well, what about this information I'm getting on the exchange in here in California? So we'll need to be prepared long before 2014, as will the state. Now, the rules are simply this. In terms of the PPACA program, they call them the American Health Benefit Exchanges. Each state will have its own name for its exchange. It'll just promote it in some particular name, whichever it may be. Now, here's the deal, though. If a state fails to create an exchange, the law allows the federal government to come in and put an exchange in that state. So where we have a state, for example, where politically the people don't want to be involved, maybe the leadership doesn't want to be involved, well, they're not going to have a choice. The feds will come in and put it in. Now, in California, we will have our exchange, so whatever the feds do elsewhere, not going to be particularly relevant to us, unless we sell perhaps in Nevada. It's conceivable a federal exchange could come into Nevada because they're pretty far behind the curve. It's conceivable a federal exchange could come into Arizona. It's conceivable a federal exchange might cross state lines, Nevada, Arizona, New Mexico. They can do it all sorts of different ways, but for our purposes, learning how we will probably be doing it in California would be the key. And we've got a great role model, our old HIPAA. Okay? What else we got? Well, application had to be made by March 2011. We, of course, did it because we had already gotten our stuff under development. By January 2013, a state has to send basically a document to the federal government saying, here's where we're at as of a year ahead of time, and here's our plan to make this thing happen. If that documentation isn't good enough, isn't moving the ball forward in a given state, like perhaps Arizona, the feds will then use 2013 to start developing the exchange in that state. Again, like I said, California's going to be fine. Operational on the 1st of the year. What else we got? Other benchmark dates. Now, this is a big one. Come January 15th, 1 year after it starts operating, the exchange must confirm to the federal government that it is self-sustaining financially. That is a huge task if you think about it. Yeah. Imagine opening an insurance company and having everything self-sustaining within 1 year. Now, the advantage on the exchange, particularly here in California, is that we're going to be using private carriers to actually back end. So the exchange is going to be more of a distribution system, so it probably will be able to pass that early test. But for every broker out there that imagines some horrible scenario where the state government comes in and, for example, underwrites the cost of premiums in the exchange, so that premiums in the exchange are half of what they are in the market, we get that kind of scare. But think about it a second. If that actually happened, what's the chances that the exchange would be viable in 1 year? Even if, yeah, slim to none, but even if you argued with me, well, they might be able to pull it off, because in 1 year, if you think about it, you only get about 6 months of experience on your claiming system, because there's always that delay process. But then how are you going to explain it the second year?
How about the third?
Or the third? The observation is simply this. The people who want an exchange to work, whether they be politicians, the left, the right, the center, or anywhere else, or bureaucrats, are going to have to deal with the reality of what insurance is. Insurance can only pay out that which it gets in. The only exception to that is if you have a state where all the citizens decide to raise their own taxes to support a poorly designed exchange. Are you going to do that? Massachusetts tried to do it, and it's upside down already. It's not self-sufficient at this point. My point being this: if our leadership does not get a properly designed exchange, by definition, it either has to come to the taxpayers for tax support or it will fail. If it fails, I may, as a competitor, have to work with it for 1 year or 2 years, and then it won't be around. But on the other hand, if it succeeds, if it is another source of distribution, I sold some business into the HIPAA, just as I sold business in the California Choice. Another source of distribution may not necessarily or inherently be a bad thing if it's designed properly. So we're going to assume it's going to be designed properly, and I'm going to argue intellectually that if it is not, it will self-destruct. And while a poorly designed exchange may disrupt markets for 6 months, a year, or 18 months, ultimately it has to fail, and those of us who are the strongest will still be around. So we're going to assume they do understand how to do this right. By the way, they could get it right. They could get it right tomorrow. You know what all they have to do? Hire our staff at Cal Choice. Just do it that way. See, positively will work. Yeah. If any deadline is not met along the way, the government comes in. So we got that timeline. Now, I put this thing here together and had it reviewed by our executive staff, and one of the executives came back and said, "Don, that thing is so small your audience will not be able to look at it." That's the whole point. What you got here, every one of these are major tasks. Every one of these tasks have been designed and accomplished in places like California Choice, except for one major function, which we're going to talk about, which is very different, and it's not what you expect an exchange to be, but it is under PPACA. And I cite this because this is all the things that have to happen by the time you launch. Now, California has many of these things already in hand from prior experience. But when we get to a state like Kentucky or Tennessee, think about how far they have to go and how quickly they have to get there. That tells me that in certain states, the federal government will have to come in with those exchanges. But I now argue the same thing I just argued. If the federal government creates an exchange that is not properly designed, what will happen to the federal government exchange? Same thing as would happen if it was improperly designed here. So, yeah, Amtrak, yeah. But they see once they stop funding the Amtrak, there's a real problem in there. And the feds are not simply going to throw money at this. So this is a very long, complicated project, which, if it's designed right, is going to be an addition to our markets, I suspect. The design is simply this. PPACA requires every citizen in the United States to get health care coverage. PPACA doesn't care where you get it. You can buy it yourself. You can give it to your son. You, as the employer, can give it to your employees. You, as a chief of an Indian tribe, can give it to your Indian tribes. Whatever it may be, it simply says if you're going to be a citizen of the United States, you have to have health insurance. But because the private marketplace right now, as we all know, has a system, in some cases, such as individuals, that precludes an individual from buying, because of either prior conditions or whatever it may be, the exchange ends up as the last resort, so to speak. It basically says, we're going to take the people who can't get insured somewhere else. And it, in theory, says, if I can get enough of these people into the exchange, it will be cheaper for everybody. Now, we're going to contest that view a little bit later, but that's the theory behind that concept. Right? Exchanges are basically the last court of pay, of the play or pay. That's the old concept of play. You buy the policy, you get in the game, or your employer buys the policy, he gets in the game, or you pay some kind of penalty in some other way to make that happen. All right? That's really what the design is supposed to do. It's run in our state by an independent state agency of 5 people who have already, the board has already been made. Two governor's appointments were made under Schwarzenegger before he left office, and that's Susan Kennedy and Kim Belshea. We're still waiting for a Senate appointee, and we're waiting for an Assembly appointee. And we already have a new HHS individual under Jerry Brown and Dooley. So in this course, when we talk about HHS, Health and Human Resources, there we go, we're talking about the state one as well as the federal one. Okay? And I'll identify which one we have. All right, what else we got? You know Mr. MIB. It's a very effective program for what it was designed to do. This exchange is being run similar on a board level to the old Mr. MIB program. All right, so we have experience on how to do that. What's the key stuff? Well, number one, the exchange has to establish and maintain a website with standardized comparative information about health plans. Now, think of it this way. An online GA. That's one of the functions of an exchange, in effect. Multiple carriers are brought in, standardized in terms of their plans and how they're quoted out, and we get the information out. Now, it has to do it on the website because that's where the bulk of the activity would be, but rather obviously, if you think about it, given that every citizen has to have insurance, and given that the exchange is one of those resorts, we have illiterate people, people without computers, people in rural areas, or whatever it may be. So it's going to have to be more than just the website. We may have to have people and systems to help those people get into the website. But it's basically website oriented. Secondly, the exchange certifies that certain health plans qualify to participate. The probability in California is that most of our carriers, the Mr. Health Nets and the Mr. United Cares and Mr. Blue Crosses and Blue Shields, they're all going to qualify. They're high standard quality plans already. But let's just assume we had a carrier in the state by the name of Lone Star Health Insurance. It could be conceivable that they've constructed their products and their plans and their services in such a way that the state would, the exchange board would simply say, you're not high enough quality, you cannot participate. Okay? So you could have some carriers in and out based upon the quality of that carrier. In our situation, most of our mainstream carriers that you typically sell, they're going to qualify if they wish to be in. The next thing the exchange has to do is has to inform, screen, and enroll individuals of eligibility for Medicare, Healthy Families, and any other applicable state or local program. Remember when I said the exchange does one thing that the HIPIC, CalChoice, and other exchanges have not done? That's it. You read what I say, but you probably don't understand the impact. What it means is the exchange is responsible for every citizen who can get free or subsidized state or federal assistance in a whole variety of programs. That is mandated. So in the future, for example, someone who thinks they're qualified for food stamps, they will go to the exchange. It will be the only place they can get food stamps. Now, if you think, yeah, remember when I said you start going, wait a minute, I didn't understand that. That's part of the exchange. The law requires the exchange to determine the eligibility of people for premium tax credits and cost sharing. People who have a certain income level get premium credits. People at a different income level might get better benefits, lesser benefits, depending upon their income. And as Craig properly suggested, that would mean they'd have to have access to the income. Yeah. You see, when we talk about a navigator, most of us read the text and assume we're talking about them replacing the broker. The navigator is a more global or collective term. A navigator could be an organization. A navigator could be the Sisters of St. Mary. A navigator could be you. But the navigator would have to have a lot more skill sets and things they have to do than simply selling the product. Now, it's conceivable in the design of any exchange that could be split up. They could say, for example, that the state does the eligibility portion And when it gets down to deciding what a person qualifies for, then turns around and sends the lead to dentist to be sold. I'm not saying they would do that. I'm saying it's a flexible enough design that that could occur. It may occur differently in Texas than it does here. Okay? So when we talk about a navigator, we're talking about a much more encompassing function than simply selling the product. And I'll get back to that when we describe navigators in depth. The exchange is envisioned primarily for individual products. When people say to me, well, will I still be in business? When you see what the exchange does, in theory, someone might say, well, individual products are really going to get hit hard in terms of sales. And I will admit, products being sold on the individual basis will have a harder time with competing with the exchange than those not. But in terms of group, the group exchange, which is known as the small business health option, is nothing more, nothing less than the old HIPAA. Employer groups will be able to apply to exchange just like they apply to Blue Cross, Blue Shield, United Healthcare, whatever it may be. California choice. The one thing to keep in mind, again, if the exchange to work, it's going to have to be pretty much a level playing field between the private market and public market. If that market tilts in some way for or against you as an individual, I think you'll see by the end of the day that its likelihood of surviving diminishes quickly. In certain circumstances, almost guarantee it won't work. So keep that in mind as you start to think, well, they're going to try to put me out of business. For example, anybody sell under the old HIPAA? Do you remember what they did with your commission under the old HIPAA?
Well, they dictated what you made, I know that.
Well, yes, they dictated what you made, but so does Mr. Blue Cross and Mr. Blue Shield. Your only option is don't sell it. But what they really did was they said, we believe the public doesn't need you. And so they allowed every small group and individual into the old exchange, the HIPAA, to get a bill every month that said exactly what you made, right there on a big box. Now, I'm not talking little print, I'm talking good-sized print, with big, easy, simple instructions that if you don't want to pay your broker, just X the box out and send the net. And 92% of all the insureds, individual and group, continue to pay their broker voluntarily every month. 92. Because the fact was, you added value to that customer. If you don't add value to that customer, he fires you as a broker right now today. Yes, the HIPAA could decide you only get paid $100, $25, $15. And if Mr. Lone Star State, if such an entity existed here in this state, decided you were going to get $25 per group, what would you do?
Go somewhere?
Go somewhere else. There's still a private marketplace. If an exchange decides it can sell without the private broker and tilts the field so much that you just don't have any reasonable reason to sell it, well, then they better be able to sell it themselves because it's a free country and you're just not going to work for them. I would advocate to you that the people who want exchanges to work are simply not that stupid. They may like to think, heck. Anybody remember when Pacific Care cut all the commissions?
Yeah.
Uh-huh. Yeah. And guess how long it stayed cut? About 6 months till somebody said, hey, we're going broke. This exchange has to operate in the real world as well as in the virtual world, meaning on an internet as well as in a storefront or with somebody walking door to door, whatever it may be. Okay? Has to do it. Now, I was asked, is this information going to be available to a navigator to check what your income is? This is what the exchange looks like, Craig. Outreach. That means sales to you and I. That means getting somebody to come into the web portal. That web portal may be accessed by Mother Teresa sitting down with the person at her desk or by you going onto the internet. But here's the part that people don't understand, particularly brokers. Once it goes into that system of eligibility, the data collected on the person gets reported to the United States Verification of Citizenry and Income, including Social Security and Homeland Security. It goes to the HHS Secretary, State and Federal. It goes to the IRS. It goes to the Medicare and CHIP programs. It goes to each state agency involved in the system, and it goes to Treasury. All of that data gets interfaced and interrelated because it has to be. The only way the system works. If the system doesn't interchange all that, then Don Goldman goes in and says, I'm poor, I only make $400, give me free insurance. And they just accept my word for it and let me go. We're talking about the greatest exchange of personal data that has ever occurred. And by the way, when we get to the point where your small employer who does not have to buy insurance decides he just wants to take all of his people and ship them over to there, they're going to have to ask his employees questions such as, do you have health insurance at your work? Does anybody have health insurance at your work? Because you see, if that employee reports, well, yeah, the upper management does, the management carve-out does, but we don't get it on the floor. That's going to set off a whole bunch of cross-checks in other departments that then discover that you, the employer, are doing something inappropriate, not illegal, inappropriate, and you have to pay a tax, a penalty, a fine, or whatever it may be. Then there's going to be other people that go into that exchange and they say, yes, we have it at work, but my owner charges me too much. That's why I'm come over here. Well, then a test has to be done on something known as affordability, and we'll look at that in a few minutes. And this system has to inform the employer that one of his employees is over here getting a premium tax credit for a subsidy because he has an unaffordable plan. Ooh. The owner who simply says, I don't care, let them report everything they want, better be pretty squeaky clean, in my opinion, if you think about it. What happens, though, is this. The question was, can I get out of the system? Once into the system will determine if you are eligible for Medi-Cal, Medicaid, any of the social programs. At the back end of the system is a shop and compare system, which is selling private plans just like you sell. But you cannot get to the shop and compare if you are eligible for those state or federal programs. You must go to the state or federal program or withdraw completely from the exchange. You don't have the right to buy the private policy if you qualify for Medi-Cal, Medicaid, healthy families, whatever it may be. That's the law. That's the law. By the way, if you get through that eligibility, you now get down to here to what is our products. The same products that we're selling, and we'll talk about what that means, and a system is put up to shop and compare those. So think of this as screening for government programs. If you're not eligible for government programs, you move back down to here, and you're now basically in a GA. It's a GA for individuals mostly in this example, but you're in a GA. You shop, compare, you enroll, etc., and off you go. The system is backstopped by private health care plans, Mr. Blue Cross, Mr. Blue Shield, whatever it may be. All right? So you kind of got the picture. It's a route. Now, there's certain rules with that route. First off, no wrong door. I come through the internet. I go to the Little Sisters of Mary, if that's who is listed as a navigator. I go to you if you're a navigator. I go to a third-party entity. I call up the DMV, whatever it may be. Okay? The system is guaranteed that anybody who wants to start in the system and go completely through the system leaves the website with the coverage. Now, that's a little extreme if one thinks about it as a single moment in time, but conceptually that's kind of like the idea. Once you get in, no matter how you get in, whether from a storefront, a website, whatever, you can flow it all the way through and walk away with a policy. Because in 2014, guaranteed issue to all citizens, no pre-X. So you have to have a system that does that. Secondly, it has to be completely invisible. In other words, if you go into that eligibility system and then you say, I don't want to answer that question, I want to get out of here, the law requires whoever's running that and designing that computer system to obliterate all your data and it completely disappears. That's what it says. That's what it says. So you do not have to, if you discover you're eligible for Medi-Cal, you do not have to take Medi-Cal. You can simply withdraw from the system at that point and go out and buy your private care if that's what you wish to do. Okay? All right, what else? We have 4 key functions that an exchange has to accomplish in order to work. Outreach, we'll call that sales for lack of a better term. Access, different ways to get into that big chart you just saw. Integration, all aspects of the program at a single source point under one roof. All these different programs exchanging information together. Interoperability, a seamless movement between either the public plan or the private plan. Let's take a look at what each of those things mean. First, the selling of the exchange, outreach. It is what it says. I may be selling it in the sense of a broker dealing with a one-on-one person. I may be marketing it like signs on a bus, for example. I may be selling it as driving around the farm fields of the San Joaquin Valley with a mobile enrollment office with pennants on it. Whatever it may be, it's some way to put the thing together. Some type of promotion. Well, I can envision that, can't you? Yeah. Point is that as it's currently conceived, this would be the one advantage of the exchange as it's currently conceived, but this is not yet locked in law, not locked in stone. The credits, the premium credits for someone, if I'm a poor person, I get certain premium credits to offset my costs, would only be available through the exchange. That would be the one advantage. Now, there's a bit of a problem here. I made the statement at class number 1 that the people who put these programs together really don't want you to go out of business, contrary to what you think. And that's because of this. People who get the premium credits, particularly fully subsidized or almost fully subsidized, who are they most likely to be? Poor people or rich people? Who is most likely to be sick in America? Poor people or rich? Yeah, you got it. What happens is the premium credit side of this thing could inadvertently suck so many of the poor people into the system that you actually create a worse risk pool than what was expected. We saw in the first 2 courses that they expect 59% more people in Medi-Cal because of this type of program. Well, that would be very upsetting because obviously in risk pool theory, the only way I get to pay your $1 million claim is to have 1 million people putting in $1 each and getting nothing back. The healthy people pay for the sick people. You just hope you have less sick people, and that's what keeps it in balance. They understand that. In Massachusetts, the reason they're having such a problem is they don't have enough private insurance in the system compared to the public insurance. So they're having to cut doctor rates, which is causing longer wait times and all that stuff we talked about last time. So what they're looking to do is to get about 17% of their total population base in the exchange in a private paying small employer. 17%. Now, I'll take your paranoia and say they're not going to pay you at all. Where are they going to get their 17% of the small groups coming into the exchange? You ain't going to do it for free. I ain't going to do it for free. They might be able to talk somebody into doing it. But heavens to Betsy, we make a career trying to convince small group people to buy insurance. I mean, we're really good at it. They think people will just line up without somebody selling this stuff? I don't think so. I think a well-designed exchange is going to say you're a very valuable portion of our process. We need you to get to our 17%, because if they don't get that 17%, they've got to offset risk somewhere else, and it gets harder and harder. They've got to get about 17% of the people in there with no subsidies. That way, that means somebody making enough personal income to pay for their insurance inside the exchange with no support. But you're still going to be in the market selling the private product. So they don't pay you. Where are you putting your people? Private, of course. We need about 63% with some regular eligibility and about 3% with absolutely just totally free, that kind of thing. So we got to get in there. Navigators steer someone through the exchange once the person makes contact. The promotion by the navigators is to make sure that the navigators are the right type of hire. Somebody's got to sell this stuff, contrary to what most of us are paranoid about. If Mother Teresa is the only person out there who's the navigator, a nonprofit, nice little sweet lady, if she's the only type of navigator they got, who's selling it? Because it ain't going to be Mother Teresa. That's not her skill set. I have great faith that the California Exchange is going to recognize just what they recognized before, which is they need brokers in the system. And I think that will occur. Obviously, the decisions at state level will make what I'm talking about, whether we have an even playing field or not. And I think what you're going to find in the end, that your paranoia about it being so out of whack that you can't make a living, I don't think that's going to be the case. I think they want this thing to work. The PPACA envisions an exchange as an additional market, not as a replacement. In many states, like the state of Tennessee, you got TennCare, which is the state health care plan, and then you got one major carrier, and that's it. There are no choices. An exchange coming into the state of Tennessee expands their market dramatically. That's the whole intent. It's not intended to replace our private. It's intended to parallel and expand our market, and most importantly, get those citizens who can't get coverage somewhere else. That is the goal, but I will freely admit, design it poorly, it could tilt the playing field, but I don't know that it can survive. So I'm going to work with Argonne to do it. Brokers are critical because we need about 40% of that revenue as unsubsidized. If every low-income worker in the state, every one of those low-income workers got shifted to the exchange and all the high-income workers stayed on the private health care plan, the exchange is going to have one whale of a problem. And I don't think, people are smart enough to understand that. So the design will be such. Broker involvement will vary from state to state. Obviously, each state will make their own decisions. Brokers could be a critical component, obviously. Nobody that I've talked to actually wants every small employer in the world to suddenly drop his coverage and push everybody that way. So we will be involved. What about access? Well, you got this portal. You don't know how to run a computer. Well, you do know how to run one, so you go through the computer, the internet. Well, what if you don't have a computer? The portal has to be by telephone. You call up the DMV guy if that's who they're going to use. You call up little company Mary if that's what they're going to use. You call up the broker if that's what they're going to use. And you access the data by telephone. There has to be some system for non-computer, paper-based, because obviously in a lot of situations, particularly in rural or illiterate arrangements, somebody's probably going to be taking that thing down manually. So they'll have that sort of input. Storefronts. There's no doubt there's going to be storefronts. You know, somebody will set it up, maybe a third-party entity called the State Exchange Distribution Company or whatever it may be. Different ways they could solve that problem. Obviously, we have the illiterate problem, we have the rural problem, but we'll have to get that. Integration. All these things must access both the private and the public plans. So when data comes in, somebody can filter it out and see which way you're supposed to go. What do you qualify which way? It'll be the only source for things like Medicare, Medicaid, food stamps, temporary aid for family, healthy families, all those kinds of programs. I already mentioned that. It must coordinate, as Craig asked, it must coordinate with the Treasury, that's the IRS. It must coordinate with Health and Human Resources, state and federal, because so many of the eligibility tests are run by those entities, and it takes the place of that. The private source, well, here's the minimums under the law. Our state could change it differently, but under the law, the marketplace must provide to the exchange, if the carrier wants to be in the exchange, 5 different designs, what we'll call the bronze, silver, gold, platinum, and sub-age 30 catastrophic. Now, bronze is not a certain level of benefits per se. It doesn't say bronze is a $500 deductible, 80, 20 to $5,000 or whatever. Bronze by the law is some plan design that actuarially covers 60% of a person's possible medical costs in a given demographic and geographical area. So, just hypothetically, if I went to Milliman and Robertson, one of the largest actuarial firms, and I said, what's the average cost of medical care here in Orange County? And if they said to me, just for the fun and easy of the example, $10,000, then any plan design that would guarantee coverage up to $6,000 of that average could be a bronze coverage. Now you say, well, how would that be possible? For example, you might have a bronze design covering 60% as a PPO, $500 deductible, 80-20 to $10,000. Maybe actuarially that meets the definition. But then a HMO might turn around and say, well, we can meet that definition with a $50 office copayment, $20 RX, $200 per hospital admission. What the specific plan design will be isn't as critical as the bronze has to cover 60, silver 70, gold 80, platinum 90. And so the exchange and its management company will go to the Mr. Blue Crosses and the Mr. Blue Shields and Mr. Health Nets and work to get a common design that meets those targets. Okay? In that way, then, if Mr. Blue Shield, Mr. Blue Cross, and Mr. United Healthcare all want to be in, they have to have some plan that is common. much like California Choice, getting a common set of benefits. In California Choice, it's more like a defined set, such as this HMO, I'm sorry, this copay, that kind of thing. But the law talks about actuarial constructs as opposed to specific plan designs. It's up to the state to decide which plans meet those goals. Okay? So, a sub-30, catastrophic, think of those as a very high deductible plan, but they will only be available to people inside the exchange under 30. Only under 30. Okay? The reason this carve-out was done is, again, this was a political process. We know from selling that high deductible plans are very popular to the richest and oldest of our population, and that was viewed as being coddling to the rich, if you will, something along that line. On the other hand, the young person who simply doesn't need as much coverage is given the opportunity to buy that catastrophic in that way. But that'll be one of the 5 plans in the exchange. They have to be able to move seamlessly between these programs in terms of this interoperability. Think about this. You got to have an ability to move people between plans. When I say between plans, I mean between public plans and private plans. Somebody is eligible for Medi-Cal. They suddenly get a job, and suddenly they're not eligible for Medi-Cal. They've got to be able to move seamlessly into the private side or into the subsidized side. You've got to be able to move people inside and outside the exchange, public to private, private to public. You've got to be able to move people based upon life exchanges, such as COBRA. COBRA's still going to occur inside the exchange. Got to be able to do that. You got to be. What if you cross the federal poverty line? You're going to discover that at a certain level of federal poverty, you get a certain amount of support. But what if you get a raise and your income goes up? They've got to be able to account for that and move the support differently. You've got to change different kinds of premium credits, all sorts of things. How about financial viability? Well, they've obviously got a contract with the carriers. That's a given. They got to have rate review. Of course, we're going to have a rate review in this state already, so again, we'll not have much difference there. There's going to be risk sharing between carriers, and this will be very critical to them. What they'll do is they will compare loss ratios between the different private carriers inside the exchange. They will then move the money. So if Mr. Blue Shield gets all the healthy people and Mr. Blue Cross gets all the sick people, and the rates are the same for both of those products, at some point in time they will analyze the experience of those two groups and say to Mr. Blue Shield, you owe Mr. Blue Cross some money. That's effectively what they're saying. What they'll actually do is simply internally change the rate at which they're paying the different carriers to keep the whole pool in balance. By the way, how important is that? That's really important, because the number one thing that happened with the old PAC Advantage was that certain carriers got better risk than the others, and then the others with the bad risk finally just said, I want out, and as more of them left, the whole thing collapsed. Yeah. So that's a very important, and by the way, that's a very intelligent way to do it. What other financial viability? Well, obviously there's going to be effective contracted medical services. We still don't have a law that says a doctor has to sign a contract, so they're going to have to set the rates on that, and it'll be market bear. In rural areas, we're still going to have a situation like in the north. We have Sutter Hospital chains, basically run 5 or 6 of the counties up there. They're the only game in town. And obviously the exchange is going to need to work with them. We may have the IPAs. Somebody talked about the networks. The networks are assumedly going to be the same. But within our state, we have the Department of Managed Health Care obligated to do financial risk analysis on an IPA. If they take on too much risk, the state has to come in and either buff them up, close them down, or whatever they're going to do. So that's going to be an issue for us. We have potential judicial conflicts. What happens if the exchange is talking about trying to mandate at a certain IPA or certain hospital in, say, Tulare, must take these patients, but the Department of Managed Health Care is saying, no, that's too much risk. They can't take those patients. So we'll have some new law put into on that play. Health care is providing, whether the provider just says, I don't want to play, provider level payments, whatever it may be. How about this one? The exchange will say, if you are at a certain income level, then we will means test you. We will notify the employer and the IRS if what they have in-house is unaffordable. Okay? And you'll get credit for that. Let's go back up to my first statement, which I skipped. If a state mandates benefits which are not part of the required PPACA program, then the state, under the law, is required to reimburse the carrier for covering those mandated benefits inside the exchange. Okay? So that'll be an interesting little additional tact. What else we got? Premiums. These premium credits we're going to analyze will be based upon the silver level, the 70% level. And if you're at a certain income level, you will be able to get reduced co-payments or reduced deductibles instead of perhaps premium credits or in addition to premium credits. For example, if a 70% actuarial value is a $500 deductible, if you're at a certain income level, you might get to pay only a $100 deductible instead. And under PPACA, the $400 that is now being paid, not being paid, would be paid by the state to the insurance carrier in the exchange. So the carrier is still made whole in this deal. Okay? Cost sharing, obviously reductions are paid by the insurers to the exchange. What else we got? Oh, the kinds of navigators. We can have all sorts of navigators. The navigators are simply required to conduct public educational activities. They have to distribute fair and impartial information. They have to be able to gather the information on the people. A navigator does all these kinds of things, facilitates enrollments, interacts with all those entities we looked at on that chart, provides information which is culturally and linguistically appropriate. Keith, that's your question. So we'll have 3,000 different exchange people. I do know, if anybody is interested, they have an opening for 2 navigators in Southern California who speak High Druid. They've already got the low and the Druids covered. So obviously you're going to need that. I mean, if you think about it, if you're trying to get everybody insured, we got a lot of linguistic issues here in California. They're going to have to cover them all. It's designed to sell a whole bunch of multiple products through a single source. We know that. There can be public and private exchanges, just like there was the old HIPIC, just like there's CalChoice for today, and of course, just like there'll be that small business health option exchange inside our bigger exchange. I want to finish up with this. Whether you are selling an individual product, a group product, what you're basically doing in today's market, if you think about it, is exactly what the exchange is going to do. Somebody, typically the employer, says to the person who's his employee, I'm going to give you a certain amount of money. Here's my money. And that amount of money is going to buy you some level of benefit. If you want to go higher, you can buy up. I've defined your contribution. Employers do that today. That's the bulk of what we sell. When we move to the exchange and we're working with or against the exchange, whichever way you're going to decide to do it, all the exchange is saying in many occasions, particularly for lower income people, is, look, I'm going to give you a certain amount of money. We'll call it a premium credit, or we'll call it a subsidy, or whatever it may be. The I who is giving it is the government in this case, as opposed to a private employer giving it. And that person will be allowed to buy up, except in the case where they're eligible for a public entity event such as Medi-Cal, Medicaid, Healthy Family. In those cases, the state's basically saying you can't buy up. But once you get past that threshold, then you can buy, you'll get credits possibly for the silver exchange, and you can buy up to the gold, you can buy up to the platinum, whatever it may be. The only difference is the credit's coming from the state, and as we're later going to find out, you don't actually get the premium credit. It gets shipped to the carrier directly, okay? So there is going to be some support inside the exchange. A couple of things you got to remember though, keep this in mind. Principally, we're dealing with individuals in the exchange. There will be a small group part of that exchange. The individuals get the premium credits and subsidies. The small businesses do not. Okay? The only way an employee in a small business gets a premium subsidy or credit is if his employer releases him, does not have a group plan, and he goes to the exchange as an individual. If the employer, as a group, chooses to come to the exchange, the shop, and buy his product through the old HIPIC type of style, the credits and the subsidies don't exist after 2014. So we're dealing with a level playing field. I want you to keep that in mind as we close off with this. You see, do you want to be a broker who is simply an expert, or do you want to talk to someone and make him a prospect? You see, right now there's a whole group of current clients and potential clients who are thinking to themselves, I can just walk away from this whole thing, just dump everybody into the exchange. We're going to find by the 6th class that's not as easy as it sounds. Because what I want you to remember in these 3 classes is, how am I going to use this to make more money? Keep a client, get a new client. That's what we want to be learning this stuff for. Secondarily, if I want to go out and talk to a client right now, have they started, well, implementation is 2 years away, have they started thinking in terms of what they're going to do? Because they're getting hammered right now by their CPA organizations, some other small business associations, or Chamber of Commerces. I've been to Chamber of Commerces that I literally had no person who owned a company over 50 lives, and every one of them swore the government was going to make them buy insurance or pay a penalty. And when I said to them, that's simply not true. If you are a 50 minus group, and we're going to talk about what that means in another hour here, you're not required to do anything you didn't do yesterday. But how many of your people are already thinking, because they're paranoid, they don't understand, and that decision, that process, the longer you let it stay in their mind that this horrible thing's going to happen, the harder it's going to be to solve that problem come November 2013 when 2014 hits you. So we want to start talking to them before it's too late. Get them positioned. Mr. Prospect, you've probably heard that a new federal health care law creates something known as an exchange. How will you adjust your company's budgeting for health care in light of the new California exchange? Because somebody's already figured out. If this guy doesn't even stuff up inside of his company and make things more comfortable for some of his employees, because right now we got lots of small employers not playing very fair. You know it and I know it. If he continues to not play fair, does he risk his employees coming over here to this exchange and starting to input information on him that right now he may not be very desirous of exposing? He's got to start thinking this thing through. It sounds very un-American, so to speak, and each of you in your political persuasion will feel differently about that comment. But the point is, I'm a broker. I'm here to help the client get through this process. So I got to at least make him be aware of it. Start doing that now.